So, the fast hug is a mnemonic that can be used for the care of every patient, no matter the pathology, no matter the management plan. You know, like I do in ICU, I always ask people, have you hugged your patient? So, like I said, it was first introduced by Juvicent, who was the then time president of the World Federation of Intensive and Critical Care Society, who actually graciously agreed to write the foreword to my book on I Fast Hug. So I Fast Hug is a mnemonic, and we need to look at what it means, and hopefully from there we can proceed to something more detailed as we go on in this lecture series. So my name is Kingsley Tobi, all right? I'm an anesthesiologist and intensivist. So we'll start with I. I in that I Fast Hug mnemonic is infection, prevention, and control. Infection, prevention, and control. Infection control is very important in the ICU based on the fact that most of our patients who are admitted to the units are immunocompromised, and they are susceptible to infection by quite a large array of microorganisms, you know. And number two is that the ICU is a hub for all sorts of infections, you know, whether bacteria, viral, or fungi, you know. And it is important, therefore, for us to ensure strict infection prevention and control. Infection, on the other hand, also can lead to development of multi-drug resistant infections. So you eventually realize that we do a lot of harm to our patients, to ourselves, and also to the healthcare delivery system if infection control is not adequately enforced. So that is why infection prevention and control is important in the ICU. And when we're talking about infection prevention, we're going to start with skin hygiene. All right, skin hygiene. If you have my book on handbook in ICU, you will see some of these things there. All right, so the first thing about infection prevention is skin hygiene. All right, and this comprises of hand washing with soap and water, all right, or hand washing with antiseptic rub, either alcohol-based or chlorhexidine or iodophos, all right. It's been documented that simple hand washing can go a long way in preventing infection, decreasing patient mortality and morbidity, and also decreasing overall healthcare costs of the patient. So simple hand washing with soap and running water is very critical for our patients in the ICU. And the era of COVID-19 has actually brought to the fore the importance of hand washing, especially with antiseptic rub, okay? And we'll be going to some of these things as we go on. So like I mentioned before, it's an introduction, and I hope that this will be the beginning of a wonderful relationship in terms of intellectual and academic relationship. The second way to ensure infection prevention in ICU is by the use of protective barriers. Protective barriers with gowns, gloves, mask, and cap. And we're going to be looking at some of the recommendations as we go on. Many of our invasive procedures in the ICU will require us to put on our protective barriers. And sometimes we call it personal protection equipment, PPE. But it's important for us to understand that protective barrier is one way to ensure infection prevention and control in the ICU. All right. So hand hygiene, like I mentioned before, is the simplest, most cost-effective way of preventing infection in the ICU. And we have recommendations for hand hygiene. For instance, you do hand washing with soap and water. Number one, when your hands are visibly dirty or contaminated or soiled with blood or body fluids. So hand washing with soap and water is recommended when your hands are visibly dirty or contaminated or soiled with blood or body fluids. Hand washing with antiseptic agent is indicated before and after each contact with your patient. Hand washing in my center here in surgical ICU. Once we're approaching a patient, the nurse will just bring you your antiseptic rub, all right, which is alcohol-based. Hey, guys, can we just mute our mics? Mostly, can you mute your mic, please? Thank you. Thank you. Let's try and mute our mic so that we can follow. So like I said, in my unit here in Windhoek, as you're approaching your patient, the nurse will just give you your antiseptic prop, all right, which is alcohol-based, and you spray it on your hand. And when you're leaving that patient to another patient, you have to use hand washing with antiseptic agent. So before and after direct contact with your patient, you need to do hand washing. Number two, after contact with body fluids, like secretions, excretions, and what have you, all right? You need to ensure that your hands are properly washed or sterilized with antiseptic agents. Before urethral catheterization, venous access, or any invasive procedures, you must ensure that you have antiseptic rub. After contact with inanimate objects that is in the immediate vicinity of the patient's bed, drip stand, what's they call it, all these infusion pumps and syringe drivers, any inanimate objects that is in direct vicinity of the patient. After such contacts, you need to do hand washing with antiseptic agents. Now, if you have any question, you can stop me at any time, then we discuss it, okay? All right, another aspect of infection prevention and control is judicious use of antibiotics. Judicious use of antibiotics, all right? And this involves what we know as antibiotic stewardship. Everybody working in the ICU must be aware and very familiar with what we call antibiotic stewardship. What it means is that it involves the judicious use of antibiotics in conjunction with infection control. So the two go together, your infection prevention measures and judicious use of antibiotics, all right, is what make up what we know as the antibiotic stewardship, all right? It incorporates appropriate antibiotic use and adequate antibiotics. Now, this means that you want to use antibiotics rightly, the right antibiotics. You want to give it at the right time, at the right dose, all right? This is what it entails. In addition, antibiotics can be given either empirically, prophylactically, or definitively. Empirical antibiotic use is that, especially following sepsis guideline, within 1 hour of diagnosis of sepsis, you must institute antibiotics empirically, all right? Before you start antibiotics, you withdraw your blood for blood culture, you do all your sepsis workup. Immediately after you have done that, you've withdrawn your blood and you have sent your samples, you start empirical antibiotics before the results of your culture or sensitivity comes out. So that is empirically. And some procedures, you may want to give prophylactic antibiotics, especially in theater, surgical antibiotic use before the skin is breached, all right? And Definite antibiotic use is when your culture, your sensitivity result comes out and you de-escalate to the right antibiotics that the organisms are sensitive to. All right, so procedure for antibiotic stewardship, the judicious use of antibiotics, ensure that you send your appropriate cultures before starting antibiotics. All right, once the patient comes and you know that the patient requires antibiotics, you withdraw your blood, you take your tracheal aspirate, your urine, you sample, you know, if there's any drainage anywhere, you want to ensure that you take your appropriate samples and send it for culture or MCS, microscopic culture and sensitivity, before you start your antibiotics. This is important because starting antibiotics before sending the appropriate cultures may actually affect the result of the culture or the sensitivity. All right, early antibiotics, start antibiotics early when it is indicated. All right, in the case of septic shock, you need to commence antibiotics within 1 hour of diagnosis. Delayed commencement of antibiotics has been found to be associated with increased morbidity and sometimes mortality. All right, in case of multi-drug resistant pathogens, combination therapy is indicated. All right, and the appropriate duration of antibiotics, before now we know that typically is 7 to 10 days, but recent studies have shown that with the use of procalcitonin as your infective marker, you can actually reduce or decrease the duration of antibiotics to about 5 days, all right? Especially if your culture has become negative and there's a favorable clinical response. I know those days we used to say minimum 7 days, 10 days, but prolonged antibiotic use when it is not necessary actually can predispose your patient developing drug-resistant pathogens. So with the use of procalcitonin and negative blood culture or negative culture in the samples you have sent, you can actually stop antibiotics within the 5th day of commencement of antibiotics. Okay, so that is about infection, the first I there of the IFAST component, infection prevention and control. All right, these are generics. We're going to be looking at it more specifically as we go on in the course of our interaction. The F is fluid and feeding. Fluid and feeding. It's important for us to give appropriate, adequate fluid and feeding to our critically ill patients. Many of them have fluid deficit. Many of them are underfed or even overfed. And each of these problems can aggravate the problems the patient has. All right. Generally, the goals of fluid should be you maintain a urine output of at least greater or equal to 0.5 ml per kg. Sometimes we want to just increase it to about 1 ml per kg per hour. All right, 0.5 ml per kg per hour should be your goal. And you want to ensure that your mean arterial pressure is greater or equal to 65 millimeters of mercury, or your systolic blood pressure greater than 100. If you have a CVP, you can transduce your CVP. Central venous pressure should be between 8 to 12 for patients who are spontaneously breathing. And for ventilated patients, your target CVP should be between 12 to 15 millimeters of mercury. Ensure that for all ventilated patients who have been administered positive expiratory air pressure, you want to ensure that your CVP is always about 5 millimeters of mercury above your set PEEP for the patient. So the goals for fluid management should be directed to these parameters that I've mentioned. And don't forget clinical response, all right? Clinical response of your patient also will aid you in determining the goal of your fluid management. Okay. Fluid therapy, there are different kinds of fluid that can be used in the ICU. We have crystalloids and colloids, all right? And it depends on the indication for the fluid, and you can make up your mind the kind of fluid that is appropriate for the patient. But for patients who are massively bleeding, or patients who are in hypovolemic or hemorrhagic shock, it's been found out that the rate of transfusion is much more important than the type of fluid in itself. All right. Instead of deciding, should I use isotonic saline or ringers or plasmalite B or dextrose or colloids, it's been found out that the rate of transfusion of your fluid is even better, is a better indicator for survival. But in some conditions, you want to avoid colloids, especially hydroxyether starch. Okay. So don't forget this principle. Give any fluid that is available to restore intravascular fluid volume. All right. It's more is better, all right, than just waiting for, I'm not going to transfuse until I get ringers lactate. No. All right. Give fluid to the patient. Fluid therapy can be divided into 3 R's, either for routine maintenance, for resuscitation, and replacement. All right, you need to determine, well, what kind of fluid therapy you are giving to this patient. Is it for maintenance? For instance, routine fluid maintenance is indicated in patients with risk of ongoing fluid loss. For example, patients with poor fluid intake, patients who have had or undergone surgery, patients with bowel dysfunction and other comorbidities that they are not able to fluid normally, so you want to do a routine maintenance. Resuscitation, fluid resuscitation is indicated in patients, especially those who are hypovolemic, patients who are in shock, all right, even septic shock. You want to do fluid resuscitation. And, you know, especially for massive hemorrhages in case of trauma or in case of in the obstetric patients, you want to give as high as 2.5 liters. But just as a starter, you want to give a bolus of 500 ml of crystalloid over 15 minutes, all right? And you may repeat this, all right, as you look at your clinical response of the patient. If further fluid resuscitation is required, you can give additional boluses of 250 to 500 ml. Fluid replacement is indicated especially in cases of fluid and electrolyte losses. You want to replace your electrolytes, for instance, sodium, potassium, even magnesium. And let me quickly add here that potassium and magnesium go the same way. So if you have difficulties in correcting potassium levels in your patient, it's advisable that you check the magnesium level. A lot of times, until the magnesium level is corrected, you may not be able to have adequate correction of your potassium level. Should I repeat that? Should I repeat that? What I meant is, sometimes if you have difficulty in replacing your potassium in case of recalcitrant hypokalemia, it is very good for you to check the magnesium level. Most of the time, magnesium level is also low. But if you start giving magnesium, all right, you realize that it will be easier for you to correct your potassium. Feeding is important. Feeding is important, which many times is often overlooked or downplayed in the ICU setting. All right, adequate feeding has been found to aid, proper recovery and the decreased length of stay in the critical care setting. So enteral feeding can either be enteral or parenteral. And we're going to look at the advantages of enteral feeding. As long as your patient can tolerate enteral feeding, please commence enteral feeding as soon as possible. It can be through NG tube or OG tube, or it can be through gastrostomy. Whatever it is, you'll need to start your patient enteral feeding. Early enteral feeding has been associated with a better outcome. Now, before you do enteral feeding, you need to determine, first and foremost, the energy and protein requirements for your patient. You are not just going to give feeding without calculating it. So you need to calculate the daily calorie requirements of the patient. All right. And a lot of times this is calculated with the formula 25 times kilogram body weight. All right. And that is your calorie intake. Okay. And you calculate the daily volume in terms of meal. So if you calculate the kilocalorie, you divide this by the number of days. All right. If you want to give 25 times maybe 70 kilocalorie, you divide it by day, and you divide this kilocalorie by meal. So this is how you infuse it in meal per hour. All right. The meal per hour is calculated by looking at the daily volume per meal in meal, and you divide it over time per hour. And this is what your patient should have. For protein intake, you want to do protein intake, we usually take in a gram per day, all right? Daily, in terms of daily volume times protein feed, is equal to grams per liter. Now, note that before you start feeding, you must be able to ensure that the residual gastric volume is less than 150. All right, you aspirate, and if the gastric volume is more than 150, you wait another 2 hours and repeat your aspiration. If it's still more than 150 mil, your residual gastric volume, after waiting for 2 hours, you want to give prokinetics. All right, and you know, prokinetics like metoclopramide, or you can even use erythromycin. All right, after commencement of your prokinetics, you want to check your residual gastric volume again in 2 hours. For patients, there are two schools of thoughts. Some give fluid continuously, all right, for 16 hours with 8 hours of bowel rest, all right? But for patients that you want to give per hour, you can actually give that, but you need to enforce what works for you. For patients who are being continuously fed, you feed them for 16 hours and you give them 8 hours of bowel rest. Are you still there? Are you listening? Are you hearing me?
Yes, sir.
Okay, great. So checklist for enteral feeding. Before you commence enteral feeding, you want to confirm that there is no gastric outlet obstruction. Okay, ensure that the end of the bed is elevated to 30 to 45 degrees. All right, give prokinetics and make sure you warm all your feet to room temperature before you commence feeding. All right, flush your feeding tubes every 8 hours with 20 to 25 ml of saline. All right, start with small volume until it is tolerated. Sometimes in my unit, we start with 20 mils, 10 to 20 mils, and if the patient tolerates it, we gradually increase. You know, sometimes we go as high as 120 mils per hour, but it depends on how well your patient tolerates it. Now, do not give fluid by push. Don't give feeding or your food by syringe. Let it flow by gravity, all right? It is better because you can monitor if this patient is tolerating your feed and if there's any kind of gastric outlet obstruction. Give continuous feed at 20 to 30 ml per hour if you're doing the 16 hours continuous feed, all right? And always ensure at all times that your residual gastric volume is less than 150 before you start feeding.
Wash first ready, it's food.
Okay. Is somebody saying something or is a side comment? Okay, so we're looking at our first talk. Let's look at airway analgesia. All right. We all know as anesthetists, we need to maintain a patent airway at all times. And maintenance of patent airway doesn't have to do with LMA or endotracheal intubation or your tracheostomy tube alone. Positioning can actually go a long way in ensuring that your patient has a patent airway. All right. What we do normally is that we monitor airway devices. All right. For every patient that is intubated or there's a tube there, you always document the depth of your tube. All right. It helps to ensure that there's no accidental extubation or accidental endobronchial intubation. You also want to constantly monitor the cough pressure, all right, to ensure that your tube has not accidentally deflated, all right. One of the things about airway management is you want to suction your oropharynx regularly. There's some, I did a work, we published it, the care of the oropharynx, of the oral care in critically ill patients. And we discovered that quite a number of our patients are not given adequate oral care. There was a case study I did in UBTH those days where we saw some worms coming out from the patient's oropharynx. All right, I actually had to report that. And we've had cases of maggots coming from the oropharynx of patients in ICU. All right, that caused to question the degree of oral care that our patients are receiving. So in management of airway, for patients who are intubated, for patients who are ventilated, adequate oral care is important because it also helps to prevent ventilator-associated pneumonia. I normally advocate for elective tracheostomy after 5 to 7 days of continuous endotracheal intubation. If your patient has been on endotracheal intubation for 5 to 7 days, you need to consider elective tracheostomy. This is important because there are a lot of problems with prolonged endotracheal intubation, with some can range from tube dislodgement, endotracheal intubation. You can even have tracheal stenosis. And I've written some papers on, tracheal stenosis following prolonged endotracheal intubation. And sometimes this patient eventually will have a lot of problems phonating, a lot of problems maintaining their airway following tracheal stenosis. So you want to prevent that by offering your patient elective tracheostomy after about 5 to 7 days of prolonged intubation. And a lot of people differ, the authors differ in what they define as prolonged endotracheal intubation. For me and for my units, we adopt 5 to 7 days of continuous endotracheal intubation. Analgesia is important. Erroneously, people think that critically ill patients do not feel pain, and because they can't self-report pain. There are different ways of monitoring pain score in sedated or ventilated patients, and there are so many of them you can look up in the literature. We have non-verbal pain score, all right, and pain, inadequate treatment of pain in the critically ill patient can actually foretell problems in terms of prolonged stay in ICU and a lot of other problems that has to do with stress response to the pain. Last week, there was a patient that had laminectomy and that was admitted to our unit. And my medical officer, the registrar, called me and was worried that the blood pressure had shot up to 200 over 1 something. And he called me what to do. The first thing I said is that let's assess the level of pain. All right. And he was on pain, he was on morphine infusion. And I felt, okay. No, morphine, was it morphine bolus and all that? So I said, okay, why don't you just give some anxiolytics? And he did that. And the blood pressure kind of normalized, because the patient felt rested. After some few hours, he called me again. The blood pressure had shot up. Eventually, before we decided to to bring down the blood pressure, we discovered that the bladder was actually very, very distended. So pain can actually masquerade in many ways. So adequate pain assessment score in the critically ill patient is important. And the gold standard for pain management is obviously opioids, which can come in form of bolus or continuous infusion. All right. And there are different opioids that can be used. I don't like continuous morphine infusion more than 24 hours for obvious reasons. All right, I prefer remifentanil or fentanyl. It depends on what you have. All right, if you're going to do continuous infusion. But multimodal approach is usually the best. All right, and a lot of our patients, especially the surgical patients, may even come from theater with epidural catheter in situ, or they can even have continuous local anesthetic agent infusion. All right, so multimodal approach is very important. And there are different routes by which you can deliver your analgesia. The intravenous route, epidural patient control analgesia, or nurse control analgesia. But the catch here is that critically ill patients do feel pain, and this pain can negatively impact on the outcome of the patient in the ICU. So analgesia is very important. The S, don't forget that we're still talking about a fast org. The S here is talking about sedation and spontaneous breathing trial. All right. Sedation patient, there's different reasons why our patients need to have adequate sedation. All right. This can range from I tell nurses before you even do your nursing care, all right, change the patient, make sure your patient is adequately sedated. All right. And a lot of things, even ventilation, mechanical ventilation, any invasive thing, even turning the patient, sometimes with physiotherapy, passive or actively movement in the ICU, all this will require your patient to be adequately sedated. And, in order to guide you, there are different sedation scores that you may employ in the ICU. It depends on what your unit is using. And if not, I want to encourage us to just familiarize yourself with one of these sedation scores and start using it, because a well-sedated patient is a happy patient. There are different sedation regimens. I'm used to the one I've been using over the years is fentanyl midazolam combination. All right, and it's beautiful because fentanyl is ultra short acting, and it also gives you analgesia. Midazolam helps you with anxiolysis and hypnosis, which your patient needs. The issue with propofol is that continuous propofol can lead to hemodynamic collapse, and there's what we call the propofol infusion syndrome, especially in children. All right. Another drug that has come into favor, which we often use a lot of times, is desmitomidine at 0.2 to 0.7 mics per kg per hour. All right. The good thing about desmitomidine is that once you stop the infusion, your patient wakes up nice and good, and it's an alpha agonist. So it also has some analgesic component to it. Other medications that can be used include haloperidol and all these other, drugs that can affect the limbic system. So sedation is important in the ICU patient. It's not acceptable for a patient to be agitated, breathless, in pain in the ICU. It's not acceptable at all. All right, for ventilated patients, you want to perform what we call spontaneous breathing trials every day. Now, this ensures that in our setting here, we do what we call sedation vacation. And I tell my people, the people that work with me, I need at least 3 to 4 hours of sedation vacation before I start my round in the morning. So a lot of my people will start sedation vacation around 4 a.m. to give us that 3 to 4 hours of sedation vacation, and then we can do spontaneous breathing trial to ensure that this patient is adequately off sedation, and the patient, we can monitor if the patient can have started some spontaneous breathing. And there are a lot of ways you can do that. You withdraw your machine support, and you can just give a TPIS, or you connect to CPAP, which you can intermittently change, all right, for increasing periods of time. And sometimes you just reduce your, instead of withdrawing your machine support, you can reduce the machine input, your pressure input. For instance, if your patient is on pressure control SIMV mode, and is at 18, you can reduce your pressure support to 10 and see if the patient can make some adequate breathing that will compensate for that reduction. And what we normally use is what we call the Tobin's index, or the rapid, what's it called, rapid spontaneous breathing index. And what it entails is you divide your respiratory rate by the tidal volume in mils, okay? So a target value of 100 beats per minute per liter, all right, is an indication for adequate spontaneous breathing trial. Sometimes if you have your Tobi's index greater than 100, it may be that your patient is anxious and all that, and you give your anxiolytic, your midazolam, you top it up, you can eventually see that the Tobi's index is less than 100. Before you discontinue your patient from ventilatory support, always perform your spontaneous breathing trial by calculating the Tobi's index. Yeah, the T is thromboprophylaxis. We know that our patients in ICU are predisposed to developing deep vein thrombosis. All right, I tell people work with me, a patient developing DVT and throwing an embolus in ICU is a slap on our face. And there are different reasons why we need to ensure thromboprophylaxis for our patients in the ICU. One, they are immobile, all right? And don't forget your VGOS trial, all right, which comes to play in development of DVT. Patients who have undergone major surgeries, all right, patients who have suffered major trauma, especially those with spinal cord injuries, spine and pelvic fractures, all right, these are patients that you must ensure thromboprophylaxis. Patients with medical conditions such as myocardial infarction, cerebrovascular disease, and neuromuscular disease are patients candidates for thromboprophylaxis. Others are prolonged mechanical ventilation, patients who have central venous catheterization, and the use of muscle relaxants. All right, these are indications for commencement of thromboprophylaxis. There are different methods that you can use. We have the non-pharmacological methods, what we call the test stocking, all right, or compression stocking. There are different types. We have the graded and we have the intermittent pneumatic stockings. The idea is you cause a differential pressure to aid venous return, all right, to the heart, all right? So every patient, no matter what, no matter the indication, should always have compression stockings in every unit I work. They must have a compression stocking, because sometimes you may not be able to give pharmacological agents, for instance, within the first 24 hours of neurosurgery or vascular surgery, where the propensity for bleeding may still be there. You don't want to give your pharmacological agents like your heparin and all that, but compression stocking can always be one for all our patients. All right, heparin or fractionated or subcutaneous low molecular weight heparin can be used in prophylactic doses. And when the patient you have confirmed the presence of a deep vein thrombus, or what's they call it, thromboprophylaxis is indicated, you want to give heparin. For patients who have developed a deep vein thrombus, all right, we need to give therapeutic doses of your heparin. And in cases where you can't give all of this, you want to insert your IVC filter. Even if there's a thrombus that has been formed in the lower limbs, you want to ensure that they don't get into the pulmonary or coronary or central venous circulation, central circulation. All right, so thromboprophylaxis is another very important component of the fast hope. Yeah, head end elevation, you can't overemphasize this. For all patients in ICU, you must elevate their head about 30 to 45 degrees. All right, it's also known as the Fowler's position, FOWLER. So indications for head end elevation or end of bed elevation, severe head injury with raised ICP to prevent or control ICP. For all mechanically ventilated patients, is part of the ventilator-associated pneumonia bundles. You want to ensure tube feeding. I mean, for patients who have been fed by orogastric or NG tube, you want to do a end of bed elevation for them. Patients who are obese, patients who are on oxygen therapy, because that position also helps with their what's it called? It also helps with gas flow. So patient on oxygen therapy should be positioned head up. For patients who are postpartum, it helps with uterine drainage. In all of this, as important as it is, you must also bear in mind the contraindications to head and elevation. For instance, patients with C-spine injury, patients who are on traction, hypotensive patients, patient with low cardiac index, patients who have colon transplant because it will reduce the viability of the transplant, and patients who are prone position. In prone position cannot have head and elevation. Most ICU beds are teachable, so it's possible for you to just teach the bed and elevate the head of the bed or of the patient. For centers that do not have teachable beds in the ICU, you can use supports like pillows to elevate the head of the bed. All right. Before you do head end elevation, make sure you rule out the contraindications we mentioned before. And some patients are falling out of bed before when you're trying to do head end elevation. So you recruit help from other members of staff, especially for obese patients, and you obtain informed consent, all right, if the patient is conscious or from their relatives. Adjust the foot of the bed to prevent patient from slipping down the bed, okay? Oh, okay, we still have 2 more to go. Also prophylaxis, all right, for patients in ICU, for all of them, all right, especially patients with history of peptic ulcer disease, history of coagulopathy, head injury patient, hypotension patient, hypotensive patient, patients in hepatic failure, trauma patients, sepsis, patients who have been ventilated for more than 48 hours should have ulcer prophylaxis. And the strategies is enteral nutrition. Like we said, early enteral nutrition is important for all our ICU patients. And enteral nutrition is actually a way of ensuring ulcer prophylaxis because of the trophic effect of the enteral feeding.
All right, what?
All right. You can do acid suppression.
Are you done?
Can you mute your mic, Agbo, Sublime? Bola, please mute your mics. Can you mute your mic, please? Sublime, please mute your mic. Somebody may call him or her to mute his or her mic. Okay. Apology accepted, Dr. Tobola. Okay, where am I? So if you're asked what are the different strategies of ulcer prophylaxis, number one, enteral nutrition. Patient must be started on enteral feeding. All right. The second one is you want to do acid suppression. All right. And the goal of acid suppression in ulcer prophylaxis is to ensure your pH, the gastric pH, is more than 4.0. And there are different drugs that you can use. All right. Your H2 blockers, all right, or your PPI, the omeprazole, and you can actually do cytoprotection, all right, where you use your sucralfate, which can actually be administered via the NG tube. Don't forget that cytoprotection with sucralfate can actually increase your residual gastric volume with propensity for vomiting and aspiration. So be careful of that. Glycemic control, this is the last one for this evening. Glycemic control. For all your patients, you want to assess for the risk of poor glycemic control by taking the history. Diabetic patient with comorbidities at increased risk of having abnormal glycemic control. And glycemic control means that you want to prevent hypo or hyperglycemia, because either of them has been found to increase morbidity and mortality among our patients. You want to see drug history. Patients who have steroids, beta blockers, vasopressor like adrenaline, your diuretics like thiazides and all that. These patients have increased risk of abnormal glycemic control. You want to also assess for the level of their glycosylated hemoglobin, all right, which actually checks the rates of control, all right, in patients who are previously diabetic. For every patient in ICU, you want to do hourly blood glucose check, all right, especially for those who are hemodynamically unstable and those on insulin therapy. And every ICU should have an insulin protocol that is pasted on the wall so that you know how to intervene for each of any glycemic readings that you take. All right, so we have come to the end of our introductory lecture, and I'm sure you have my book, Tobi's ICU Handbook, Fast Organ Principles of Organ Support. Any questions, any interaction is welcome at this moment. Any question, any contributions? You can mute your mic if you have something to say, people. Abdulkadir Mohammed. Any comment? Adebukola Salami. Any comments? Shika Mario Josiah. Any comments? Anybody, please go ahead. The night is fast spent. It's 11 o'clock from my end here. Dariola, are you guys here or you slept on me?
Thank you, sir. Good evening, sir. Thank you, Prof, for the wonderful presentation. Really so that we can go through.
I can't hear you.
Hello, am I audible now?
Yes, you're audible now. Yes.
Thank you very much, Prof, for the wonderful presentation. We really appreciate it.
Okay.
My request, sir, is if we will be given this light to go through it, we'll be glad, sir.
It's in your book. It's in my book that you have.
All right, sir, we'll look at it.
Sorry,
Yes.
sir, how can we get it, sir?
Lucy, you don't have the book?
Yes, sir.
Oh, are you on that group or you on the WhatsApp group?
Yes, sir.
Okay, we'll send you the contact there, no problem.
Okay, sir.
All right. Okay, sir. Thank you, sir.
Thank you, sir.
Okay, somebody said Fatima Odushote. Thank you, sir. Can you please shed more light on cytoprotection on ulcer prophylaxis? Yeah, like I mentioned before, cytoprotection is one way of instituting ulcer prophylaxis, but it's not, from my experience, not my first line. All right, I'd rather do the PPIs and even sometimes a continuous infusion of PPI, especially for patients who have some bleeding. All right, but cytoprotection can help covers the gastric mucosa, so prevent it from the acid effect, but it does not reduce the acid production. What PPIs and the H2 blocker do is they reduce the acid production. But cytoprotection, like sucralfate, aluminum oxide, and all that sulfate, they cover the layer of the gastric mucosa and protect it from the effects of the acid. But the acid is still in the stomach. Okay. So do something. I don't know if that helps. Fatima, does that help?
Yes, sir. Thank you, sir.
You're welcome. Ojo Adetola, Ojo Lawale, are you twins? Ojo Adetola and Ojo Lawale. Dr. Onya, which Onya is this? I have a classmate, Emeka Onya. Is this Emeka Onya? No, it can't be.
No, it's not, sir.
But you know Emeka?
Emeka, no.
Emeka Onya is a consultant in the East. We're actually classmates. Okay, great.
I don't know him, sir.
You need to meet him.
Okay.
Fortune Uzwegbe, any question? Ibrahim Fari? Okay.
Good evening, Chief. Pleasure to be here. Thanks for the lecture.
All right. We thank you.
Oh, sorry, I joined up a little, maybe into it though. I was just wondering, so I did a better part of the earlier section. I was just wondering, communication, effective communication in the ICU protocol and your experience. How that plays out in management, in patient management, effective communication now. Thank you.
Yeah, effective communication is important, and that's what we try to do. You know, everybody is important in the ICU, the nurses, everybody. So effective communication is important. Everybody should know what we're doing part-time, and everybody should be able to anticipate what needs to be done. So effective communication is very important. Everybody knows, and that is why protocol is important in ICU. If there's any unit at all that requires protocol and strict adherence to protocol, it is in the ICU. So when we have a protocol in place, everybody familiarizes himself or herself with the protocol. It also aids with communication in the management of the patient. And for me, I allow everybody to make an input. All right. Nobody's an island in ICU. I could miss something that you will not miss. So it's a teamwork. ICU is a teamwork. Yes. Any other person? Mohammed, Musa?
Yes, sir.
Please put your mic.
Hello, good evening, sir.
Good evening.
Sir, I'm sorry, I just joined the meeting. I was overwhelmed with work. So I just joined the meeting. Sorry, sir.
No problem. We have done for today. We are just taking questions and comments.
Yes, sir. I'm even following the question. I'm even getting from the question, actually.
All right.
Thank you very much, sir. Thank you very much.
Joseph,
I
carry
asked the question on the chat group.
On the chat group.
Yes, I don't know if it's there.
There's
the
no
first
question
question is on
here.
Oh, okay. The network is bad for this thing. Thank you very much, sir, for the presentation. Okay, for sedation in ICU, can you please explain propofol infusion syndrome? Because there are instances where propofol is used as a sedative when it is used as a complication.
Hey, Musa,
And
we
my
can't,
second
you're not
question.
allowing us to hear Dr. Olaoye.
Sorry, sir. Sorry, sir.
Please mute your mic.
Okay, sir.
So I was asking about the use of propofol as a sedative in the ICU.
Yes.
The complication as regards propofol infusion syndrome. So the indication and the complication, I didn't try for the thing. Then second is to expand more on the spontaneous breathing trial, how it is done. Thank you.
All right. Yeah, let's start with the spontaneous breathing trial. You know, don't forget that one of the indications before you institute invasive mechanical ventilation, the indication must be reversible. Okay, that is one very important thing we need to understand. All right, once you establish that the indication for your invasive mechanical ventilation is reversible, then you start your your spontaneous breathing trial. And before you start it, you want to calculate your Tobin's index, all right, which is respiratory rate over tidal volume, all right. For instance, if your respiratory rate is 25 and you look at your tidal volume, all right, from your ventilator, you calculate that. And if it's less than 100 beats per minute per liter, you are confident that this patient will pass. The idea is that you want to see if your patient will pass your spontaneous breathing trial. Because until your patient passes that spontaneous breathing trial, you cannot win the patient off ventilator. So once you calculate it and the patient is less than 100, the lesser the value, the better. All right. And your patient is able to, passes the, rather gets a Tobin's index less than 100. You want to, there are different ways of doing this. You can reduce your machine support, reduce it. For instance, if the patient is on a pressure support of 18, for instance, you want to reduce it to 16, to 14. And what you're doing is that you are gradually releasing the patient from ventilator and you are encouraging the patient to take more spontaneous breath. And it's a lot of ventilators, you can actually see patient breath, you can see the machine breath, all right, until you see that. Or you can discontinue the patient from the ventilator and attach the patient to a T-piece, all right, or CPAP, all right, initially for maybe 30 minutes, 1 hour, then you connect the patient back, then you do it again, okay? Then these are the ways that you can ensure that your patient undergoes spontaneous breathing trial. But before you do this, always ensure it goes hand in hand with sedation vacation. Like I mentioned before, most of my patients, we do sedation vacation between two to 4 hours every day. Early in the morning before the ICU round, sedation is stopped and we can assess neurological state. We can also assess for spontaneous breathing trial. About proportion of continuous propofol infusion, it's been found to be very good, especially for patients that you have difficulty with adequately sedating them with with fentanyl and midazolam. I hardly use propofol infusion, all right, but where it has been used, well, you need to be sure that your patient does not go into hemodynamic compromise. And for propofol infusion syndrome, is actually as a result of high lipid load. And it is not something that is significant in the first 24, 48 hours. And it's actually also worse in children. So propofol infusion syndrome is not something that is very common, especially if you have it less than 48 hours of infusion. But my worry is more of the hemodynamic compromise that can come with sometimes. For patients who you will require propofol infusion, all right, that was not adequately sedated with opioid-based, you can imagine that they will require higher doses of propofol, which can lead to hemodynamic compromise. Yeah, Dr. Dari, I don't know if you are satisfied with that comment.
Thank you very much, sir.
You're welcome. You're welcome. All right, somebody's hand is up. Please go ahead. Whose hand is up?
Yes, sir. Good evening, sir.
Good evening,
Thank
Salis.
you so much for the wonderful presentation and enlightenment. So I don't know. I want to get your opinion on the role of entraining oxygen while weaning or liberating patients from mechanical ventilation. Despite the fact that we know the use of TPs, CPAP, and some other means, some are still practicing and training oxygen and all that. So I want to know your opinion and what is the standard while
and training oxygen in terms of using Venturi tubes or what?
Yeah, no, using either nasal catheter or improvised catheters to entrain oxygen via the endotracheal tube while disconnecting the patient from mechanical ventilation.
Well, the issue is that, you know, it depends on the settings. Most of the time, you know, you are not, you know, there are too many things involved. If you're just going to put a nasal catheter into the endotracheal tube, just to supplement oxygen, it's been done, but in this kind of patients, you are not, you are just oxygenating. There's no ventilation in terms of with the help of the patient. So if the patient is hyperventilating, you can have hypercapnia, even though you're supplementing with that. And another thing is that you are not, a variable performance oxygen device, because you are not controlling the oxygen you are giving to this patient. And it becomes worrisome in COPD patients where you want to give control. The use of Venturi tubes is better in this wise, especially if you are able to liberate your patient from ventilator and you want to just gradually come down on your oxygen concentration. And the use of Venturi mask or Venturi tubes comes handy. And you know, they are color coded, and we have this color coding that we used to use those days. You know, beware of young rich girls. Beware. B is blue, W white, you know, orange, young that is yellow, red, and green. Okay, you know, and green is about you know, each of these color codes have FiO2 that, you know, is given to this patient. And the use of Venturi tubes actually is better because it gives you a controlled measure of oxygen delivery. So it's been a long time. Where I practice, we don't do that anymore. And even in UBTH those days when I was there, I hardly have to use oxygen, nasal catheter and all that to entrain oxygen into my endotracheal tube. All right. If you have other means, I would suggest you do that. But because you can't, you don't have control over the FiO2 you are delivering to the patient. You don't have control over ventilation. And even though you are solving the problem of hypoxemia, you may not be able to solve the problem of hypoventilation with hypercapnia. And some of them, you can actually lead to a blunting of the opposite drive that some of these COPD patients have become used to. All right. Somebody.
Thank you, sir. Thank you, sir, for this. Really appreciate it.
You're welcome. Thank you, sir, for this session. Please, sir, what is meant by ethics of ICU? Fortune, did I mention ethics of ICU today? Or you want us to discuss something else apart from the lecture today? Fortune Uzwegbe. Let's reserve that for some other time so that we don't get derailed. Okay. Ojo, are you still, your hand still up or what? Or the former hand?
Yes, sir. Good evening,
Okay.
sir. And thanks for the, I'm fine. Thanks for the lecture, sir. I want to raise objection concerning sedation in ICU and propofol, sir.
Objection sustained.
Thank you, sir. The use of propofol in ICU for sedation, I wouldn't know, sir. I want to be sure. Does propofol infusion syndrome occur in adults? Because what I know is you can have propofol infusion syndrome in pediatric age group that are lesser than 3 years. I don't know.
That's what I mentioned. As I mentioned that is common only in children, propofol infusion syndrome. But I said there are other problems with it, with the hemodynamic compromise that prolonged high dose propofol will bring on board, especially in our patients. All right, propofol infusion syndrome is commoner in children, and I mentioned that in the course of the presentation.
All right, thank you, sir.
All right.
Yeah, Chief, well done, Chief Tobi. I was just wondering to add my own comments into that. Yes, commonly in children, also in some patients are critically ill and maybe underweight or undernourished.
Yes,
that adults could also have that experience. There's I read somewhere about the Bristol's regimen. Bristol's regimen in propofol use. I think where you're almost like a sliding scale, kind of, that gives variation in terms of starting dose 8 milligram per kg or so per hour, then you step down to 6 to 4 to 2, as it were, tailoring it to the patient state and hemodynamic consideration. But like you said, it's not the most ideal in that regard for sedation. My comment, Chief, is regarding pain management in the ICU. Like I said, I joined up a little late for patients. They are using the template you outlined because of different consideration on routes or routes and ease of administration, where there are no syringe pumps, as it were. That's the first part. Then the second part, depending on the level of ICU, where one operates, level 1, 2, or 3, or the type, how do we avoid the drug-drug interaction? That's just your experience now. I mean, you've done your rounds, the surgeon does his rounds, and the treatment sheet is having 2 pages that has to be managed. So how do that interface occur from your own vantage point, sir? Thank you.
Yes, for me, I've over the years gained the respect of any other person coming to the ICU, all right? And I've, by God's grace, found a way to make them know who is in charge, okay? And as residents, it may be difficult for you, but when I was in UBTH, everybody knows that what Tobi has not sanctioned will not be given to the patient. And if I have any UBTH resident here, they will bear with me. And the nurses know it, even if I'm not there, and anybody, any surgeon or any internal medicine guys comes and prescribe anything, they will not give it until they get clearance from me. All right. And it's not something that comes just like that. It comes with years of people having to trust your judgment, people you have to earn your respect, all right? Knowing fully well that a coordinated care, it all goes well for everybody, both the patient and the managing team. So the truth is, like what you said, depends on where you practice.
As it makes it sound as if it's a healing institution.
Please, can you mute your mic, please? All right, if you are practicing in an open-ended, multidisciplinary ICU, there should actually be a lead, an ICU lead, all right? that everything is coordinated and everybody is on board on the patient care. And what I do a lot of time is I ask them, I want to see the treatment sheet for this patient. How many medications is this patient on? How many medications do this patient really need? How many of these medications can we strike out? Because a lot of time polypharmacy, drug interactions do more harm than the intended good. So it comes with communication, like somebody mentioned before, with all the managing team, coming to terms to see that, okay, this is what we agree that this patient should be on. And this should actually be audited on a daily basis. Even if sometimes if you do your round more than once in a day, all of this must be audited every time you do a round to ensure that you do not give a patient what the patient does not need. All right, does that answer your question?
Absolutely spot on, sir, always. Chief,
all right.
Well done.
Thank you. Guys, if there's no other question, can we call it an evening? And hopefully we can sustain this, even if it's once a week, where we can have some topics. I've got quite a number of topics, interesting topics, but from anesthesia, ICU. And sometimes we may even look at questions and answer them together on this forum. The idea is we pass information and knowledge to everybody that we can be better practitioners anywhere we find ourselves in the world. Thank you very much. I'd like to call it a night. Do have a wonderful evening. And those of you who are on call, please take care of our patients and God be with you. All right. Have a wonderful evening.
Thank you, sir.
God bless you.
Thank you, sir. Good night.
Good night, everybody. Thank you.
Good night, sir. Thank you, sir.
Good night, sir.